And with that, we will go over to the panel discussion. I would request Dr. Deen Dayal to occupy this chair. Dr. Nagori, if you can come on the dais. And Dr. Asha, if you can join the three eminent people here. We'll have a panel discussion. We have about 30 minutes. And I would include the question and answer session to Dr. Deen Dayal in this panel discussion itself. If you have questions, please feel free to ask them, and our eminent panel will help us understand each of them.
To start with, it's working? Working. Shall I start with a question? Ma'am, many a times we have seen that day 3 FSH is high and the antral follicular count is low, but AMH is also high. It never correlates.
That's a beautiful question. I was always told by my teachers, you call it a beautiful question when you know the answer. Well, the concept that Dr. Asha talked about is 3 different aspects. Number 1, the FSH is high. So what does FSH tell you? FSH will tell you about the antral follicles only. The AMH. What does AMH tell you? It tells you about the pre-antral follicles. Then it's normal. That is because when you're doing an antral follicle count, you have a low AMH, you have a low antral follicle, but your AMH is high. It's normal. So what does that mean? When 2 people are saying the same thing and the third one is saying something different, the third person is wrong, which means your lab is wrong. So how can a lab be wrong? I mean, it's very bad for me to sit here and say the lab is wrong. Let me tell you, my dear friends, a few things that I learned over the years about AMH. Number 1, when you collect the blood for an AMH testing, it should be processed. That is, the serum must be separated within half an hour. That is number 1. The sample of serum should be processed within 48 hours. If it is not processed, AMH is a very, very sensitive molecule. It breaks up, and 48% of the AMH values will double if the sample is processed after 3 days. So if you get an AMH that is high and it's not correlating with your clinical picture, you need to change the lab where you send your AMH samples. Always send your AMH samples to a lab which has a high rotation of work. You can't send it and keep the sample for 1 week. At the end of it, they pick up their samples and they process it. You're going to get wrong reports. That is something I learned over time. So, number 1, do your AMH sampling correctly. Number 2, if you have a situation like this, there is a young woman. She's 23 years old. She has a high FSH, a high AMH, but low antral follicles. For some reason, these women do much better and have nearly the same pregnancy rates because FSH indicates quantity, age of the patient indicates quality of the oocyte. So between quantities and qualities, you always like a younger husband, not an older husband, because the older husband has more money, but the younger one has more power. And what you're looking at is the younger one. So it's the same with the ovaries. Have I got my message across?
Yes, ma'am. Are there different AMH cutoffs for Indian population, ma'am?
Why are you asking me all the questions I know answers for? Makes me arrogant at the end of it. All right. We have worked with Beckman Coulter, Uh, we have now in the center got the automated version, and we are using it from January. But when we look at, there are two assays. Can I give a long answer? There are two assays. One is the Gen 1 assay and one is the Gen 2 assay. The Gen 2 assay is 40% more than the Gen 1 assay. That means in the Gen 1 assay, if your value was 1, in the Gen 2 assay it will be 1.4. You must remember it's more. So you must always ask the person who's doing your AMH, please tell me which assay have you used. Is it the DSL? Is it the Gen 1? Is it the Gen 2? And make sure you pick up the phone and talk in front of your patient, because she'll be absolutely impressed. And you'll be impressed with yourself, because the values that I'm talking about just now, which we did with Beckman-Coulter, for the Indian women, any value less than 1.2 is poor responder. Between 1.26 and 3.6 is normal responder. More than 3.6 is hyperresponder. More than 5, we see very high incidence of hyperstimulation syndrome. And this is how we look at. Dr. Nagori.
What I've seen is that AMH investigation has become a fashion. If you don't do AMH of a patient, means people know that you are not knowing the recent things. I don't understand a regular practitioner does ever require AMH. In a regular gynec practice, in a regular infertility, I'm not talking of an IVF. Do you require AMH, and what the information does it give, which is going to help you the line of treatment?
Can I answer this? Today is the day. Okay, see, on a panel, you must have two people, first of the opposite sex, second who differ. Because if we agree on everything, then one of us is not needed. All right? So with this in mind, Dr. Nagori, you and I practice infertility. And you and I are dealing with a subset of patients who have failed repeatedly. The patients that come to your clinic and mine are usually over 35 and have failed extensively. You are making a stimulation protocol, and you don't do the AMH, you go only on her antral follicle count, and you see an antral follicle count of 10 or 12. One moment, I haven't finished. I'm a woman, I haven't finished. No, we're just arguing because it's pre-lunch. Yeah, it makes me hungry, so. And I have a young lady sitting at the back.
I know you will not see it, you will go away for your flight before my answer.
Actually, Margaret, who's sitting at the back, gave me a tablet for my headache. So I'm really fresh, Margaret, now, thanks to you. So as far as the AMH is concerned, you have a patient. I mean, I never used to do an AMH in the past, but I started to believe in it. You have a patient with an AMH or an antral follicle count of 12, and you don't do her AMH. And she lands up with hyperstimulation syndrome, though you've just got about 5 or 6 oocytes. In the court of law, when you have to fight, you have to be straight with your answers. I've done her AMH. I already warned her that she has a high chance of hyperstimulation. You can give her her trigger and you can handle her much better. That is number one. Number two, we have women who are unmarried who come to us and say, please tell me whether I should have a baby. Marriage is not the point. Should I have a baby now, or can I postpone childbearing? And she's an unmarried girl, and hopefully she has not, in the Indian scenario, has been sexually active. So, and transabdominal ultrasound is not going to tell you very much. So you do an AMH level in the gynec scenario to evaluate her ovarian reserve and say, you know what, if the AMH is 3, you say, okay, you can take some time before you find the ideal man, which at the age of 70 also I don't think we'll find. But you can at least tell her to wait.
See, what I wanted to convey is that now regular gynecologists are regularly going for AMH. Does it have any significance? Number one. Second thing, if you have got an ultrasound and if you know the antral follicle count, there can be a debate, but there are lots of paper which say that AMH and AFC has got the equal predictive value. Now, what is AMH? AMH is your salary of the whole month. And what is AFC? What is available in your pocket today? So, if you are stimulating a cycle, then your AFC is much more important, because approximately 60% of the eggs you are going to collect if you stimulate this patient according to antral follicle count. And that's why only AMH will not suffice. It should be combined with AFC, and AFC can stimulate. But once again I repeat that for a regular gynecologist, AMH is not required. Please don't spend the patient of this 2,000 rupees just for getting the AMH done. It does not give you any information, it does not change your line of treatment, and that's why a good ultrasound will suffice for a regular gynecologist rather than going for AMH.
That's why the lecture of how to do a good gynec ultrasound.
We open the floor to any questions that you may have. I'm sure Dr. Nagori and Dr. Deendayal would be pleased to answer those questions.
Anything related to infertility?
Hello. In hypo also it will be helpful AMH when you do. Like sometimes in day 2 scan you will not find any antral follicle, and when you know AMH value you can start with low dose. These are the patient who hyperstimulate also. There the AMH is as a role. Otherwise not much like clinical practice.
See, your clinical diagnosis is hypo.
But when you do FSH LH only, you'll get to know.
Whatever it is, your
Otherwise
line of
you'll not get to
treatment
know.
is not going to change. If it is hypo, you know that you are going to give HMG to this patient.
But you
It
will
is
start
not
with a
going
lower
to
dose
help
sometimes.
you for the change in line of treatment.
No, they will have adequate antral follicles actually. They hyperstimulate. When we start stimulation with 150,
All
when we
patients of
try
hypo go for hyperstimulation. You always get multiple
we
follicles
do have like
in
borderline
all
categories.
hypo.
What's your question?
Actually, AMH has a role.
Her statement was that there are certain cases where AMH is better than AFC. Am I right?
Yes.
Yes. There are only 3 conditions in which AMH is better than AFC. An unmarried girl wanting to get to postpone childbearing. Number 2, in a patient whose ovaries are post-operative in adhesions, and you really can't make out the antral follicle count because the whole ovary is hazy. When the ovary is involved with endometriosis and you don't know what the reserve is. And the 4th is the hypo. For example, if you have a hypo with AMH of 5, when you start stimulating these women, you go slow on your HMGs and not go at a 150 dose right away. But if you have an IVF center, then you can always convert it. But I think these are the patients who are hypo, where you cannot give a GnRH analog trigger and prevent hyperstimulation syndrome because they don't have LH. You have to give them HCG. And you can push them to hyperstimulation syndrome. So I completely agree with you that a hypo, you must do an AMH level definitely so that you can monitor your dose.
Do you both believe in mild stimulation with clomiphene and GNS? Do you both believe in mild stimulation with clomiphene and GNS?
I don't believe I practice because it's not possible for many of our patients who cannot afford to buy. See, letrozole was one of the most beautiful drugs. It's out of the market. I completely agree about anastrozole, it never works. If I have to use pure gonadotropins, I totally agree with you, Nagori, that using gonadotropins, particularly the recombinant, it works. But how many of our patients are going to afford it? And at the end of stimulating, if you say, you know what, you're hyperstimulating, now we need to cancel your cycle, it's horrible. And if she conceives multiple pregnancies, it's much worse. because then you deal with the overload of multiple pregnancies. And I think at this point of time, the most important thing is that you need to use a combination of both. If she's a very young woman and she hasn't responded to clomiphene, you add clomiphene and a little of gonadotropin and try 1 or 2 cycles before you say pure stimulation. Either change your husband and marry a rich man or take a bank loan. So I think I would still use it. In practice, I use it, and I don't want to deny that.
In IVF, ma'am?
In IVF, I don't use it.
You don't?
In IVF, by the time the patient comes to you, you only say 1 cycle, and that 1 cycle do full justice to it. So on principle, I use only recombinant. Maybe if she can't afford it, I'd use a urinary product, but I do not use clomiphene. However, if the patient is a poor responder, what we now do is use clomiphene and HMG and pool the embryos and then do a transfer. That's the only place I use clomiphene, nowhere else.
Thank you.
One of the use of AMH, what has been documented, and which I believe I have written also, that people used to go only for 4 punctures for ovarian drilling, which is a wrong concept. And you should drill, the number of punctures are according to the stromal volume. And that's why there are current papers available that you do an AMH of the patient, do an ovarian drilling. If AMH has not decreased, your drilling is not going to work. What does it indicate? That the amount of drilling should be according to the higher the AMH, higher the number of punctures, higher the stromal volume, higher the number of punctures. So AMH must decrease with your drilling, otherwise it is not going to help you.
Ma'am, would you introduce yourself?
Hello, sir. I'm Dr. Shubhada. I'm practicing in Nagarbavi. Sir, I would just like to know, in a patient with the single tube, if the follicles develop only in the opposite ovary, are we still justified in doing an IUI?
I will not do it.
Okay, sir.
You're asking me? If the other tube is healthy, I won't clamp it. If she develops an ectopic again in the other tube, I won't give her methotrexate, I'll clamp it. That's the only time I'll clamp it, because it's like this, Meenakshi. You cannot, in the court of law, sustain the action based on experience. And I think all the time we have to think of, what does the lawyer think, what does the law say, and how am I justified, and can I protect my backside in the court of law. So I think there is many things that are justified, but not in the court of law. So I think we need to not only, I think I heard something from a very interesting doctor, and she said, I tied the first knot on the vessel for controlling the bleed. I tied the second knot to have peace of mind and sleep in the night, and I put the third knot for the lawyer.
Sir, just an extension of the previous question, sir. So if the HSG says there's a block in one tube, other tube is normal, and the follicles are in the opposite side, so we can go ahead with the IUI, sir?
Before doing IUI, I will do laparoscopy. I will not rely on HSG.
For all cases, we have to do laparoscopy before IUI, sir?
Okay, I differ. If the woman is young and you've done a histosalpingogram and you find one tube is patent and the other tube is not visualized, not blocked, but not visualized. If the patient has no symptom or features suggestive of pelvic adhesions after a good ultrasound, if there is a 3D reconstruction shows everything is fine, I will go ahead for an IUI. Most likely, the dye has taken the passage of the easiest passage, and the other one was just a spasm of the tube. So I think I would go ahead with an IUI. However, if she is a IUI failure, then I would certainly resort to doing a laparoscopy and correcting the problem, probably even cannulating the tube. But I do not do a laparoscopy for all my patients. If the patient is on the older side, has an obvious reason for a laparoscopy or a previous abdominal surgery suggesting adhesions, or my ultrasound suggesting adhesions, then I do a laparoscopy. Otherwise, I'm pretty satisfied with the histosalpingography as a preliminary.
Why do you do HSG? You see that is a young patient, freely mobile, your ultrasound is normal. I don't think there is any need of doing an HSG. It means everything is normal. If you want to try, you straightway try rather than doing an HSG. But you can't go half-hearted. If you want to know exactly the status of the tube, then you should go for endoscopy. See, remember, your failures increase now, then the patient will go to somebody else. There won't be any chance of doing a laparoscopy by yourself. It will go to somebody else.
Such a typical male answer, isn't it? All males are problem solvers. Chat, chat. For a woman, it's like emotions and style.
Ma'am,
You're so male.
Ma'am, can you please tell us some points on the clomiphene citrate plus gonadotropin protocol for stimulation? You said you will do it for a few IUI.
Question for me?
Yes, ma'am.
I look at the antral follicle count. I look at her, first is her age, her married life, her antral follicle count, her AMH, occasionally, if the AMH is not done, her FSH, her previous ovarian stimulation, and has she hyperstimulated in the past? Based on this, if she's a normoresponder, then I would use 25 milligrams of clomiphene. I never go to 50 very easily because I'm using gonadotropins, and I don't want the anti-estrogenic effect. This is how I do it. So 25 milligrams of clomiphene citrate, and along with that, on the last day of clomiphene citrate, I start using urinary gonadotropins, because the recombinant gonadotropins, either which way, are not required, because you have LH anyway from clomiphene. So it really doesn't matter if you have little more LH in your gonadotropin. So for IUI cycles, I use 75 units of a urinary gonadotropin for a period of 3 days, and I monitor them. And of course, like Dr. Nagori had mentioned, very nicely, and probably I must admit, I learned this from Dr. Nagori, and I started to use these parameters before you give your HCG. Thank you, Dr. Nagori, I learned it from you. He trained my children as well in ultrasound. Dr. Sonal trained my children in his institute. So I find that giving the trigger at the right time is the way to go. So I give them clomiphene, 25 milligrams for 5 days. On the last day, I start urinary gonadotropins for a period of 3 days and start monitoring, and then according to the values, then I give the HCG. However, if you're dealing with a PCO type of ovary, I start with 25 milligrams of clomiphene and use 37.5 of urinary gonadotropins. I divide it into half and make them, I really don't know whether I'm justified, but I'm getting my pregnancies. So I use 37.5, or if the patient can afford, I use 50 units of recombinant preparation, because you get it in pens and you can nicely adjust 37.5 or 5. So I use recombinant in those cases. And then of course the same thing about the trigger. So this is how I use clomiphene. If the patient has had anti-estrogenic effects of clomiphene, I use 40 milligrams of tamoxifen, 20 to 40 milligrams of tamoxifen. This is how I use it, and I'm saying it end on. I don't have the evidence, but it works for me. It'll work for you. And if it doesn't work, then you have IVF.
Thank you, madam.
Hello, ma'am.
Remember, in the practice, once again, in the practice, when the patient comes to you, patient has a set of mind that I'm going to stay with this consultant for this many months. So always do your best. Don't leave it on the patient, don't consider any other thing, because if that patient does not conceive, will go to somebody else. That's why when the patient has come to you, you have to use the best for the patient to reach the highest pregnancy rate. Otherwise, patient is going to leave you. So don't do any trials on the patient, that this may help or this may help. This should help, and patient should conceive. Because there are lots of patients who come for 1 month, for 2 months from overseas, for 3 months, or they have visited so many doctors, they are tired of all of us. And that is why, even in spite of that, they have come to you. So they should conceive. That's why go with the best protocol, which is giving you the highest pregnancy rate. That will improve your practice and pregnancy rate.
Now you understand he comes from the land of Modi. Modi wants to do everything immediately before the next government takes over. So I think the most important is you counsel your patients. You logicize with the patient in the presence of a very important person, and her name is mother-in-law. Counsel the husband, counsel the mother-in-law, and counsel the patient before you give a protocol, and rationalize. And look at the mother-in-law when you talk of costs. Look at the wife when you talk of results. Don't bother about the husband, because he'll listen to his mother any which way.
Hello, ma'am. My name is Dr. Nirmala. I'm a consultant in Kalyan Nagar branch. Can you please share your experiences on sonosalpingography?
When you say experience, I will tell you how I do it first. Make sure that you, 1 day earlier, you use a betadine vaginal tablet, because you cannot allow any infection in the uterine cavity. Having done this, you call the patient, just give her a slight sedation. Not necessary, but we do it because it's a little painful. Take her to the theater. Don't do it in your outpatient, with an ordinary catheter, a very fine catheter, like an IUI catheter. You hold the anterior lip of the cervix, put in the catheter. You get special sonos. We use the special sonography, those catheters that you get, which dilate, which have a little bit of a dilated part, a little bulb that dilates, and then inject 5 ml very slowly, and use your 3D probe. So as you're injecting, 2D is all that is required. As you're injecting, look at the distension of the uterine cavity, and since we have 3D, I quickly sweep and get a volume, save it, and it's on my hard disk, and I can reconstruct it later on. But if you have only a 2D machine, just watch it and look at the uterine distension. I think a saline sonohystrography is very good for intracavitary lesions, particularly to separate out a polyp from a submucous myoma. It is an awesome method, a septate uterus, an anomaly of the uterus. You can define beautifully Escherman syndrome, intrauterine synechiae. You can beautifully demonstrate this on ultrasound and sonohystrography. As regards to its use in tubal patency, I must admit I have never ever been satisfied. In these cases, HycoC works very well, but HycoC is not available in India, so they still depend on hysterosalpingography. Personally, I have never been satisfied with tubal evaluation from this procedure. Probably.
HycoC, there is one of the company in India who brings HycoC and can give it to you. I will give you the number. But it's only one company who is giving, and 5 ml bulbs are available, and that works beautifully. Once you take a sweep, you can beautifully see the tube. And fortunately now, recently we have taken E10, where you can exactly see the lumen also, by having a different contrast of the wall and as well as the lumen. So you may not use it as a primary, But suppose you have done a laparoscopy, the tubes are blocked, and once again you want to evaluate it, then you can go for it. Somebody has done a microsurgery and then you want to evaluate, then also it will be very good. The main advantage is that you can see the fimbria very well with a hycosi. You can beautifully see all the fimbrias, whether they are normal or not. So that is very good. Instead of HSG, you would go for hycosi, that will be much, much better.
Doctor, listening to you, I may have to go back and read Men Are From Mars, Women Are From Venus.
It's an awesome book. At the point in which I can tell you that it made such a difference that I thought they were talking about my husband. My husband thought they were talking about me. It's an awesome book, John Gray's.
John Gray.
Awesome book, each and every one of you. Don't worry about buying a textbook of ultrasound or gynecology or obstetrics. Just go and get your latest of John Gray's concept of men are from Mars and women are from Venus. They will describe you in the bedroom also. It's beautiful. It's awesome. It's awesome. Awesome. This is Mr. Mars.
All right, any other questions?
Exhaustion? So it is with here.
Thank you very much.